Hello everyone and welcome to this module on vesicoureteral reflux. Now, this vesicoureteral reflux is one of the simplest examples of why direction matters in the field of medicine. Okay. Now, before we jump into the topic proper, let's try and understand what is the meaning of this particular sentence. Now, I will give you the gist of what we're going to study throughout this particular module over the next minute or so. So once you kind of come to terms with what we are trying to deal with, the rest of the module is going to become easy. Okay, so our train of thoughts will sync at that point of time. Otherwise, this topic can become very confusing. So some basic things that we need to know: the urine that's produced in the kidney will come down through the ureters and empty into the bladder. Now this ureter, where it joins the bladder, that is what we call as a vesicoureteral junction. I'm sure all of you know that. Now this is ideally supposed to be a one-way junction. That means urine from the kidney and the ureter should come down, but the reflux or the retrograde thing should not happen. Why is that? That is because bladder and the urethra have a potential of harboring bacteria. So if there is a reflux, there is a chance this bacteria can go up the ureter. It can of course damage the ureter and the kidneys in the form of pyelonephritis, and some sort of chronic renal disease can occur because of this. So the whole idea is, if there is a vesicoureteric reflux and there is an associated UTI, it can lead to dangerous problems. So your idea is to try and prevent UTI in patients who have this vesicoureteric reflux. Second thing, this vesicoureteric reflux more or less is seen in children. That means it is some sort of a congenital problem. That means something that's going to be picked up at a very, very young age. Most of the times it's less than 1 to 2 years of age. At the same time, this is something that can spontaneously resolve over a period of time. So your idea is, till the time that it resolves, try to keep the patient safe from UTI. So treat them prophylactically, make sure they don't develop UTI. Automatically the VUR will subside by itself. Patient will live a normal life going ahead. Now the next step, by chance if your medicines don't prevent UTI, or in spite of treating them, the UTI becomes very complex, these are indications for certain surgical and endoscopic procedures, which we will see as we go along. So this is the basic gist of this particular module. Now all of this boils down to one fact, that urine from the bladder is going back into the ureter. So that one area, if something goes wrong, something as simple as a UTI can end up with something as bad as a chronic kidney disease because of repeated scarring and damage to the kidney. That is why they say direction matters, especially in a case of vesicoureteric reflux. So first let's quickly talk about the embryology of this vesicoureteric junction. See, the bladder is something that is arising from the urogenital sinus. So this green one is the urogenital sinus. The blue one is your mesonephric duct. Okay, so you're going to have your pronephros, mesonephros and the metanephros. The metanephros is what gives rise to the ureters and the kidney. This mesonephric duct will join the urogenital sinus. Okay, so that is where the bladder comes in contact with the mesonephric duct. Now this particular area will eventually kind of dissolve. So what happens is, the ureter will directly communicate with the bladder at that point of time. Okay, so this is the uretrovesical junction. So if you have noticed, it is not that the ureter is directly going and joining into the bladder. The ureter is initially kind of emptying into the mesonephric duct. The mesonephric duct connects with the bladder, and that part of the mesonephric duct will kind of vanish or get absorbed into the bladder, and then the ureter comes in contact with the bladder. So that means there is no direct communication. There are certain methods or certain procedures that happen in between before the ureter comes in contact with the bladder. So certain rotations and all are involved. So if there is a problem at this point, that means if the ureter joins the bladder too soon or too late, that is when that particular junction can be malformed and can lead to reflux. Okay, so this is the embryology of the vesicoureteric junction or the uretrovesical junction. Now I told you that it is supposed to be a one-way flow. Okay, that means from the ureter down to the bladder should be one way. Now what are the mechanisms that maintain it in that one-way channel? Okay, now these are called as a anti-reflux mechanism. Amongst them, the first one is the peristalsis of ureter. Ureter is a dynamic structure, correct? It keeps pushing urine down. So there is peristalsis. So this active peristalsis of ureter prevents the reflux. Why? Because the ureter is pushing from top. So the chance of urine coming back from the bladder towards the ureter is kind of minimized by the effect of the peristalsis of the ureter. Second is the anatomical composition of the uretrovesical junction or the vesicoureteric junction. Two things that you need to know. One is the intramural length. Okay. And the second thing is that the outer layer of the ureter combines or continues as the outer layer of the detrusor. Okay. The outer layer of the ureter kind of continues as the outer layer of the detrusor. And this is what is called as the Waldeyer's sheath. Okay, that is what is called as the Waldeyer's sheath. Now again, because it's a continuation, whenever the bladder contracts, here also there will be contraction, it prevents the reflux. We'll talk about this intramural length in the next slide. Okay, and the last one is the functional dynamics of the bladder, and at the same time the ureter also contracts. So whenever the bladder contracts, the ureter also contracts. So this prevents reflux of the urine back up into the ureter and into the kidneys. Now you need to know how this ureter enters into the bladder. So let's assume this is the bladder. You have outer layer, you have inner layer. This ureter runs through the bladder and then empties inside. Okay, and then it empties inside the lumen of the bladder. Now this particular length is what we call as an intramural length. That means the length of the ureter within the wall of the urinary bladder is called as the intramural length. And its ratio compared to the diameter of the ureter is what is important. Okay, the intramural length is to the diameter of the ureteric orifice. This is supposed to be 5:1 to make sure that there is good amount of natural anti-reflux mechanism happening. Okay, by chance if this ratio is very low. So if the ratio is very low, that will lead to vesicoureteric reflux. Why is that? Simple. Have a look at here. Because it has a long length and it's coming inside, whenever the bladder stretches, okay, whenever the bladder stretches, that means whenever there is filling of the bladder, can you see that this gets pushed up? So there is a collapse of this ureter that's happening inside the wall of the bladder. Alright. So whenever it gets collapsed, of course the urine will not be able to go on top. Okay, it prevents the vesicoureteric reflux. So remember, this value is important. Intramural length is to the ureteric orifice, or the diameter of the ureteric orifice should at least be 5:1, and this was described by Paquin. Okay, so this number is important. Why? Because whenever we talk about surgery and reimplantation of the ureter, our goal is to try and achieve this number. Okay, that's as simple as that. Now let's look at the demographics. I told you in our introduction that this is a condition that has the ability to resolve spontaneously. So in short, it is a transient condition. And if you look at the prevalence and the incidence of this particular disease, overall it's about 30% in general population. Okay, various studies have showed various numbers. Let's just stick to one of them. Okay, this is what's mentioned in Campbell. All right, overall it's about 30%. But the maximum incidence is in the very, very young children. That means in the infants. All right. So at the age of 0 to 12 months, the incidence is as high as 56%. And as the age progresses 1 to 5 years, the incidence drops down to 15%. But overall, the incidence is about 30%. Now, in the presence of UTI, they've seen that the incidence is higher. It's about 30% whenever the child has UTI. That does not mean that UTI is causing a VUR. No. It basically means whenever they have UTI, we will evaluate and investigate them, and we have found out that the chance of VUR is higher in these children. Okay, it's as simple as that. Now, if a child does not have any issue, why will you unnecessarily investigate to see whether the patient has VUR? We don't tend to do it. That is why the incidence in general population tends to be lower, because we don't test them. But in the presence of UTI, because you test them, the incidence seems to be higher because you pick it up that much faster. Now, going ahead, about 17% of patients who underwent some sort of cystography for non-urological causes. Like I told you, this is a general population. They have done VCUG for some other cause, okay? And in such patients, they have found out that there is some sort of vesicoureteric reflux. Most of the times, these children will also have hydronephrosis, okay? That means basically you have done this for some other cause and incidentally picked up VUR. So again, it boils down to the fact that whenever there is UTI, the incidence seems to be higher as compared to when there is no active UTI. Okay. With regards to gender predilection, male babies have a higher risk of developing VUR. Okay. Rather than developing, there is a higher incidence of us diagnosing VUR in males, almost 3 times more than that of a female, in the first 6 months of life. But as we progress, once the baby reaches 21 to 24 months, the incidence between the male and female are the same. Okay, male and female are the same. But as age progresses into adulthood and teenage and so on and so forth, female becomes more common than male as the age progresses. Okay. So that was regarding the gender predilection and its association with the vesicoureteric reflux. Next is with regards to age. As young the baby is, that much more is the incidence of VUR. Okay. Now, as age progresses, the incidence comes down. And can you think of one good reason why this will happen? Simple. I told you this is a self-limiting condition. That means it can spontaneously resolve in most of the times. So if it can spontaneously resolve, as the age of the child increases, probably the child had VUR and it is resolved, and now you are testing, there is no VUR. Are you getting the point? So that's the reason why in young children, the incidence seems to be the highest. Okay. So like I said, it is significantly more common in younger children. At the age of 2, the incidence is as high as 38.6%. And as you see, as the age increases, the incidence decreases. So in 12 to 21 year age category, the incidence drops down to as low as 7.6%. Moving on to race, they found that black children, okay, that means especially that also female black children, there is a 10-fold reduction in the risk of developing VUR. Okay, 10-fold reduction in the risk of developing VUR, and this is seen in the female black children. But again, as age progresses, the incidence tends to become normal as compared to that of a general population. Okay, the VUR becomes equal after 10 years of age. So once the age goes beyond 10 years, whether it's male, whether it's female, whether it is a black child or a white child, whatever it is, then the incidence almost tends to be the same. Now, coming to inheritance and genetics, they have tried to look at whether this is a familial or a genetical condition, and it is, but they are unable to kind of pick up as to what gene it is. So why did they come to this conclusion that there is some genetics involved? That is because there is something called as a sibling vesicoureteral reflux. That means, for example, if I have VUR, my younger brother has a risk of developing VUR as well. And they found that the incidence is sometimes as high as 50%. Certain studies quote 30, certain studies quote 50. So it can be as high as 50%. Alright. So if my sibling has it, that means most of the times it has to be some sort of a familial or a inheritable or a genetic problem. But they've not been able to kind of pinpoint as to what gene it exactly is. And they found that the risk is more for younger siblings. Again, no major idea or sense behind this. Again, everything comes down to common sense. I told you, younger the child, more is the incidence, correct? So if I have VUR, My elder brother probably would have developed VUR and it has got resolved. So if you check in him, there might not be VUR. Whereas my younger brother, because he's still small and you test for VUR, there is a chance you will pick it up there. So that's why they say younger siblings have a higher risk of VUR. It's as simple as that. Now they also say that siblings who are younger than 3 years of age of the patients who present with VUR grade 3 to 4 should be screened. That means, do all siblings need to be screened? Certain guidelines say yes, but you can give them an option. But if by chance my VUR grading is 3 or 4 or above that, okay, that means 3 or 4 or 5, my sibling must be checked. Okay, that means if the grade is high, the chance of my younger sibling also having it is very high. So if you know that my younger sibling has a VUR, start them with antibiotics, make sure they don't develop UTI so that he doesn't have pyelonephritis and he won't have some sort of chronic kidney disease. That is the idea behind all of this. Okay. Now, siblings, okay, I told you 50%. What about identical twins? Now, identical twins, they say the risk is even higher. Okay, it is even higher when compared to that of the risk of VUR in siblings. One study showed a 100% concordance rate. That means if I have an identical twin, if I have VUR, 100% my identical twin will also have a vesicoureteric reflux. Now let's look at the types of the vesicoureteric reflux. There is something called primary, something called secondary. Primary means there is some abnormality in the vesicoureteric junction and this is a congenital problem. Okay, congenital problem in the way that it is developed. That means something wrong with the embryology. That means when the ureter combines with the bladder, some issue happens, right? If that happens, then it is called as a primary vesicoureteric reflux. Secondary, on the other hand, is because of certain other causes. See, here urine is going up the ureter. Now that can be either because of that valve which has got damaged or because of a bladder outlet obstruction. Okay. So if there is a block here, the bladder will distend. Okay. Eventually, the urine will go up the ureter and can cause kidney damage as well. Now here the main cause is the bladder outlet obstruction. So you're getting the point. So it need not be only a problem at the vesicoureteric junction, but anything apart from that also, if there is a problem, that can also give rise to the VUR. Okay, and that is what we call as a secondary vesicoureteric reflux. Let's look at more examples in some time. So talking about this primary VUR, like we discussed, it's a congenital defect in the structure and the functioning of the uretrovesical junction. That means that one-way flap is lost for some particular reason. Now in these patients, they can have a dilated ureter, intrinsic stiffness of the ureter, and abnormal bladder characteristics. So these are the findings that you're going to find whenever we deal with primary vesicoureteric reflux. What about secondary vesicoureteric reflux? First one is something that can cause increased intravesical pressure. Okay, that means for some reason the pressure inside the bladder is increasing and that is causing the reflux of urine into the ureter. Now this increased pressure can again be because of two reasons. One, it can be an outlet obstruction. That means something that is blocking the outlet leading to an increased pressure. And in that the most common cause is the posterior urethral valve. Okay, posterior urethral valve. This is the most common cause of outlet obstruction causing VUR. That means this is the most common cause of the secondary vesicoureteric reflux. Now the other cause is non-obstructive. This is because of a neurogenic bladder. So in neurogenic bladder, what happens? This area is very sensitive. So even if one drop of urine comes into the bladder, okay, the bladder muscles are triggered violently and there is aggressive contraction of the bladder muscles. So whenever there is aggressive contraction, there is a chance urine can reflux back into the ureter. Second is if there is anatomical abnormality of the vesicoureteric junction. See, even in primary VUR, I told you there is some anatomical abnormality, but that anatomical abnormality is associated with embryological problems of the uretrovesical junction. But there can be certain embryological problems around it. Okay, that means not exactly the junction, but around it. That means in close proximity. One is presence of a uretrocele. That means some abnormality with the intramural part of the ureter. That is one of the cause, like a uretrocele. A duplication of the ureter. Okay, in duplication of ureter, in congenital abnormalities of kidney, we have covered it. In duplication, you're going to have an upper and a lower moiety. The upper one is obstructive, the lower one is the refluxing one. So if they ask you in uretrocele, which the upper or lower is going to have the VUR, the answer will be the lower one, because that is a refluxing one. Then is the presence of diverticulum. Now this diverticulum can either be para-uretral diverticulum, or the ureter is entering into a diverticulum. That means either the diverticulum is here causing weakness of the VUR, or the bladder itself as a diverticulum into which the ureter is entering. Now why this is important is, if it's a para-uretral diverticulum, it can be managed with medicines. That means it can resolve. But if the ureter itself is entering into a diverticulum, do you think this diverticulum will heal by itself? No. So spontaneous resolution of VUR becomes unlikely. That means these are conditions where you need surgery. Okay, some sort of reimplantation of the ureter to make sure the patient is cured from the vesicoureteric reflux. Now coming to this neurogenic sort of VUR, okay, the neurogenic cause for the secondary VUR. Patients with spina bifida, almost 30% of them had a vesicoureteric reflux. These patients had recurrent UTI and incontinence. But when we talk about spinal dysraphism, how do you know this patient has spinal dysraphism? Okay, so in these patients, there will be a sacral dimple, there will be a hairy patch, there will be gluteal cleft abnormality, diminished rectal tone, lower extremity sensory or motor deficits, or significant and often refractory constipation or encopresis. Okay, so this is how your suspicion should kind of go up regarding spinal dysraphism. That means all these findings will be there whenever we are dealing with a case of spinal dysraphism. Again, VUR is seen in these patients. Okay, those who are known to have spinal dysraphism and VUR, a more proactive approach should be taken to manage the lower urinary tract. Okay, and that is what is generally recommended and advised. Now let's look at certain other conditions which can cause the VUR. Okay, other causes for the secondary VUR in short. One is the bladder-bowel dysfunction. So let's just take a second to think about it. I'm sure all of us have seen this. If a patient is constipated, they can tend to present with a retention of urine. Okay, they'll come with a bladder which is kind of distended with urinary retention. Now, whenever there is urinary retention, can it harbor bacteria? Yes. If there is a lot of post-void residue which is kind of sitting there, that means the bacteria can tend to grow in it and it can become infective. Now, because of this urinary retention and the retained urine being infective, when it refluxes up into the ureter, it can cause pyelonephritis. Okay, so please note that it need not be only urological cause for VUR. It can even be a gastrointestinal cause for developing VUR, and that particular thing is called as the bladder-bowel dysfunction. Now this is an acquired abnormality, and again here these patients will have UTI and a vesicoureteric reflux. Why? I've already told you. One, because of the retention. Second is because of the increased post-void residue into which bacteria can keep kind of growing into, and then the reflux of infected urine up into the ureters. Now these patients, okay, these are patients who are scared to go and move their bowels. They'd rather be constipated and struggle because of some sort of social problems. Okay, now if this behavior becomes prolonged or it intensifies, the bladder voiding pressure increases. So basically this is a sort of obstructive secondary VUR. Now here continence is gradually exchanged for incomplete emptying. That means because of the spasm which is led to the urinary retention, so that means continence is there, and the continence is gradually exchanged for incomplete evacuation. Because the bladder is distended so much, it is never able to completely contract. Only a little bit it will contract, send a little bit of urine, the rest of it tends to sit there. Again, this is an infective foci. Now these patients, like I said, because of the retained urine, have a higher risk of developing UTI. So how do you treat these patients with this bladder bowel dysfunction? Invariably, there is no spontaneous resolution. Why? Because unless you correct the GI cause, that means unless you correct the constipation, the bladder issue will not settle, and if the bladder issue doesn't settle, the risk of pyelonephritis is always there. Don't expect the VUR to settle by itself. That is the bottom line. So for these patients, you can try some sort of behavioral therapy, biofeedback therapy, and when it comes to medications, you can give them anticholinergic medications. So these will kind of help the neck of the bladder relax and allow the urine to come out. Okay, so this is the treatment of the BBD, okay, bowel and bladder dysfunction. Now, why are we talking about treatment of some third condition rather than talking about treatment of VUR? That is because whenever we are dealing with secondary VUR, it is our duty to first treat the cause for secondary VUR before you try and deal with the vesicoureteric reflux per se. First treat the cause, that means treat the cause which is leading to the VUR. So once you treat the cause, only then you will be able to deal with the vesicoureteric reflux. Next is about lower urinary tract dysfunction. So in the presence of lower urinary tract dysfunction, the incidence of VUR is as high as 33%. Now what's important to know is that whenever these patients have this lower urinary tract dysfunction, the VUR is usually of a lower grade. Okay, it's of a lower grade, and in the presence of lower grade, that means the reflux changes are not that great. So when you do an ultrasound, it tends to be normal. Okay, it tends to be normal. And if the ultrasound is normal, there is no indication for you to do a cystoscopic or a cystographic study, okay, like a VCUG, that we will again talk about in some time, okay, because VCUG is the gold standard. So if there is no indication, you can't identify the reflux. Now this lower urinary tract dysfunction, again at the end of the day, will lead to some sort of urinary retention, which eventually causes UTI. Okay, so it is associated with febrile UTIs, and it should be meticulously investigated with ultrasound and VCUG, that is the voiding cystoureterogram. That is because, again at the end of the day, we come back to the point, unless you treat the lower urinary tract dysfunction, there is no point trying to treat the VUR. It will never work. That is what the funda or the idea is. Okay. Now, any child for whom the standard therapy of your lower urinary tract dysfunction, that means you have diagnosed the cause and you're treating it. If it doesn't work, that means if the symptoms of your lower urinary tract disease doesn't subside, then it is an indication for you to undertake a video urodynamic investigation. Okay. That is the indication for doing a video urodynamic study. Next is the role of circumcision and the effect of phimosis on VUR. Now they have said that in non-circumcised children, okay, non-circumcised children, there is a 12-fold greater risk for developing UTI, and there are two reasons for this. One, whenever there is phimosis, it is nothing but a outlet obstruction. Keep it in mind. It is nothing but an outlet obstruction. So outlet obstruction will lead to retention of urine, some sort of postvoidal residue. Again, that can harbor bacteria, that can cause infection. Second thing is harboring bacteria. Now, underneath this phimosis, that means underneath the prepuce, there can be smegma. That means there can be colonization of the bacteria. Now, this becomes hub. So anytime the bacteria from here can enter via the urethra, go into the bladder, and then from the bladder go up into the ureter if there is a VUR and cause major complications. Okay. So circumcision, they say, is slightly protective whenever we deal with the case of VUR. Okay. So like I said, two reasons why phimosis can cause increased risk of UTI. One, there can be an outflow obstruction. Second, the smegma or the dirt that is sitting underneath the prepuce can harbor dangerous bacteria. So far we spoke about the primary, the secondary VUR. Now let us see how to diagnose this VUR. Okay, what are the investigations that we are going to do? Now I told you these are very, very young babies. So for you to subject them for any particular test, you need to have an indication. Otherwise, you can't keep doing this scan or test for each and every child. So the first and the most basic complaint that these children come to you with is some sort of history suggestive of UTI. Okay, some history will be there. Some sort of febrile episodes will be there. Some sort of UTI, that means burning micturition sort of symptoms will be there. Okay, so these are things that you need to look for. So idea is try to look for UTI and try to treat it. Okay, so your job is to confirm the presence of urinary tract infection. Why are we bothered about this? That is because if there is UTI along with vesicoureteral reflux, it can cause pyelonephritis. Repeated pyelonephritis can cause damage to the kidney. The kidney can shrink, can reduce its function. Okay, so there is a sort of nephropathy that's happening because of the reflux, and that is what we call as the reflux nephropathy. Okay, reflux nephropathy. Now, an addendum to this is that all this is an acquired cause. This is not a congenital problem. That is why this is called as the acquired reflux nephropathy. Why? Because all of this is acquired after the birth of the child. This is not something that is a congenital sort of an issue. Okay. Second is, like I said, take a good history, talk to the parents, ask them for febrile episodes, ask them for burning micturition, ask them for high colored urine. Okay. Whether the child is drowsy, lethargic, disoriented, all these are symptoms of a generalized sepsis sort of picture. So these are the history that you are going to pick up. Once you have suspicion that there is UTI, you need to confirm your diagnosis, and the confirmation is done by sending a simple urine routine. So if there is UTI, there will be bacteria in the urine that is called as bacteriuria. Now at the same time, you also need to look for proteinuria. Why is that? That is because whenever there is a reflux and there is pyelonephritis, like I said, it can cause damage to the kidney. So if the kidney is damaged, it is not doing its function of reabsorbing all the elements. So protein can be lost in the urine. So if there is proteinuria, that means there is already some sort of problem in that particular kidney. It is not functioning well. So now that you have done that, okay, in your urine routine, you have either found proteinuria or you have found bacteriuria. Next step is to do a urine culture. Okay, so first do a urine routine. If that is positive, go ahead and do a urine culture and confirm your diagnosis. Now moving on to radiological investigations. Please note that we are dealing with very, very small and tiny and fragile babies. That is because, like I told you, most of the times it's picked up less than 1 to 2 years of age. Now the problem lies in these two scans. Okay, they are the gold standard. They're the gold standard. That is a voiding cystourethrogram, and RNC stands for radionuclide cystogram. Okay, these two are the gold standard. But the problem is both of these have some sort of radiation exposure. Okay, radiation exposure. So your idea is to try and limit this radiation exposure. Now you might ask me, sir, this is the gold standard, and at the same time you're asking us not to do the investigation. So what is to be done? Do something safer, that such as an ultrasound. And in the ultrasound, if there is something abnormal, then go ahead and do the VCUG or the RNC, that is the radionuclide cystogram. Okay, so first perform the ultrasound. If it is abnormal, then go ahead and perform the VCUG and the RNC. Now, what are the patients in whom you will subject them to these tests? Children with UTI less than 5 years of age, all children with febrile UTI, or any male patient with any sort of UTI. These are all indications for radiological evaluation of the vesicoureteric junction for vesicoureteric reflux. Now, what is common amongst all three is this word of UTI. So the best way of remembering, if there is UTI, go ahead with the tests. If there is no UTI, then all your guidelines and all come into picture. So first is regarding the ultrasound. Now, the American Academy of Pediatrics have recommended that patients who are younger than 2 years of age with the first febrile UTI should undergo ultrasound as the initial diagnostic test. Okay, where USG is considered the initial diagnostic test, And by chance in the USG, if they find certain evidence of reflux, that means a dilated ureter or a renal pelvis, something of that sort, then you're going to subject these patients to VCUG, that is the voiding cystourethrogram. Okay, so basically if you have significant findings on ultrasound or recurrent UTIs, that is when you will be performing the voiding cystourethrogram. Now a little bit more detail regarding this voiding cystourethrogram. There are two types. There is an indirect and there is a direct. So before we do that, let's quickly remember what is a voiding cystourethrogram. So what you're going to do, you will fill up the bladder with some sort of dye, okay, and take 3 films. Before the patient urinates, last one is after the patient urinates, and in between, during the act of urination, this is done under a dynamic study. That means a fluoroscopic guidance, okay, done in the OT under the help of the C-arm. So you're going to have 3 phases, that is the pre-void, during voiding and the post-void phase. Okay. Now, idea is how to instill this contrast inside the bladder. Your job is to try and instill the contrast. There are 2 ways of doing this installation of contrast. One is give the contrast IV. It will go into the kidney. It will get filtered into the kidney. Then from the kidney into the ureter and ureter into the bladder. So you can see the contrast coming from top. Now this is a bit tricky. That is because you can see dye coming from top. You can see dye in the bladder and you have done your film. Now you don't know whether the dye which is in the ureter is the dye that is coming from top down or the dye that has refluxed from down to top. Okay, this distinction is not possible. There is no way of trying to identify which of the two it is. Okay, so that is the reason why this indirect VCUG is not preferred. It is not preferred. Instead, what's preferred is the direct VCUG, where we put in a transurethral catheter and inject the bladder with some sort of contrast materials and then do this radiological investigations. Now, when we talk about this VCUG, this is also called as cystographic imaging modality, and this VCUG and the radionuclide cystogram, that is the RNC, like I've discussed, they are the gold standard for identifying a vesicoureteric reflux. This also we have covered. The VCUG is a fluoroscopic study. That means you're going to take a pre-void, a dynamic phase in between. As the patient is urinating, continuous films of X-rays will be taken, and that is the dynamic phase. And finally the post-void phase, that is a VCUG. Now, 2 things to be noted. The bladder is filled with gravity. That means don't inject the dye into the bladder. Don't do that. So when you inject, there is a chance you can cause some sort of damage. Instead, just allow it to fill with gravity. At a certain point, it will stop. That is when you are going to cut off your infusion of the contrast into the bladder. So like I said, you will be taking certain static images. Static images means before and after. Okay. So in this, you will be able to see the bladder contour, presence of diverticulum, ureterocele, and grades of reflux. Okay. So these are the things that you are going to see in the static images of the VCUG. Now, along with this, you can see sometimes a passive reflux. Okay, even though you have done it only under gravity, that means you have not pushed, there is a chance that some amount of dye might leak up. This is called as passive reflux. Okay, that's called as a passive reflux. Now, this obviously means that there is something called as a active reflux. Now, this active reflux is demonstrated during voiding. That means the second phase. First is pre-void, last is post-void. In between, during the act of micturition, they will be using a fluoroscopic imaging modality. Okay. So at that point of time, as the bladder is contracting to push the urine out, some amount of reflux might happen into the ureters. Okay. Now this is what we call as active reflux of urine. Okay. Now the other points that can be appreciated on a VCUG is what is the condition of the bladder neck, funneling, and the urethral patency. All these can be made out whenever we are dealing with a VCUG. Now please make it a point to get delayed films. That means wait for at least 10 minutes. Wait for at least 10 minutes before you take the post-void film. Why? Because the whole idea is Once the bladder contracts, the dye will go up into the kidney, okay, and you expect the dye to come back down into the bladder. Now, for some reason, if it doesn't come back down and it gets stuck in the renal pelvis, now you're dealing with two problems. One, lower end, the VUR is there, that is the abnormality of the vesicoureteral junction. And second, on top, you're going to have a uretropelvic junction obstruction. That is why once the bladder contracts, the urine got refluxed into the kidney but is unable to get out. Okay, so these are some things that you're going to find only on a delayed film. Don't expect to pick this up in your early films. Okay. Second thing, delay your VCUG by at least 1 week if there is active UTI present. Okay, if there is an active UTI, do not try to do a VCUG because you can further push up this particular bacteria into the urinary stream. Now, based on this VCUG, okay, based on the VCUG, you can grade your vesicoureteric reflux. Okay, so there is a pictorial representation and a theoretical representation of the same classification. Grade 1 is reflux into a non-dilated ureter. Grade 2 is the reflux can go up to the renal pelvis, the calyces, so on and so forth, but there is no dilatation of the ureter. That is what you need to see. Finally, in grade 3, you will start seeing dilatation of the ureter. Okay, grade 3 is mild to moderate dilatation of the ureter, the renal pelvis and the calyces. Okay, and there is very minimal blunting of the fornices. Whereas when we come to grade 4, there is ureteral tortuosity. This is the first time you are going to see tortuosity in grade 4. Alright, so you will have ureteral tortuosity and dilatation of the pelvises and the calyces. And grade 5, there will be gross dilatation of the ureter, pelvis and the calyces, and there will be loss of papillary impressions and ureteral tortuosity. Okay, so these are the classification of the vesicoureteric reflux, and this is based on what? The VCUG. Okay, based on the voiding cystourethrogram. Next is radionuclide scanning. So here what you're going to do, you will inject some sort of radioactive material into the patient's urinary bladder. So the bladder contracts, this particular radioactive material will go into the ureter, and when you use your specialized gamma camera, you can see this radioactive element in the ureter, thereby confirming your diagnosis of a vesicoureteric reflux. Okay. Now what you need to know is that this particular radionuclide scanning is ideal both as a screening modality and for monitoring the natural reflux or the surgical follow-up of reflux. That means, one, I told you that this reflux can spontaneously resolve. So you have gotten a scan done now, repeat it after some time, the child is asymptomatic. It will tell you whether the patient is recovering or not. First one. Now another point or the advantage of this radionuclide scanning is that there is lack of confounding imaging density. What do I mean by this? First, let's go back to the VCUG. VCUG is basically what? It is an X-ray, correct? So on an X-ray, you can see a stone, you can see a bone. How to differentiate between the two? Very, very difficult on an X-ray unless you are very experienced and there is gross distinction. But if both of them happen in the vicinity of a major particular area, it becomes very difficult to differentiate the two. Why? Because there are certain imaging densities which kind of prevent your complete or thorough evaluation. So, whereas in a radionuclide cystogram, I already told you, idea is to push in radioactive material and then use a gamma camera. So here I am not bothered about bones and all, I am only bothered about what is the area of the body that takes up that particular radionuclide dye. Alright. So there is no lack of confounding imaging densities. Okay. So there is no confounding factor here. And the second point is the ability to obtain prolonged exposure. Again, let's go back to VCUG. And then you have the phase in between, which is the dynamic phase. Okay. Now, during this dynamic phase is when there is maximum exposure to radiation because you are doing firing after firing of that particular X-ray machine. Alright. So, you're increasing the risk of radiation exposure. So, here in a radionuclide scanning, you have already given the radioactive dye. Okay. Here there is no role of using X-ray. You are only using gamma camera to catch the energy or the waves that are being given off by that particular radioactive material. Okay. So here whether you do the scan for 1 minute, whether you do the scan for 1 hour, the exposure or the radiation will be the same. So this is a major advantage when compared to the VCUG. And please note that the greatest advantage of using this radionuclide scanning is whenever you are dealing with grades 2 to 5. Okay, that is where it is kind of going up into the ureter, there is dilated ureter, all this you're going to see that is in that particular bracket. Whereas in grade 1, it is poorly detected. Why? Because we know that the intramural length of the ureter is quite long. So even if you're given a radioactive material, if it stays inside the ureter and the ureter gets masked behind the bladder, which also contains the radionuclide material, it gets missed. Why? Because there is overlapping. So in such scenarios, they have found that the ability of the radionuclide scanning to identify VUR in grade 1 reflux is poorly detected. Okay. Now, this is an image of a radionuclide cystogram. Here you can see this is grade 1, grade 2, grade 3. You can see the dye kind of going up into the ureter. Here it's gone into the kidney. Okay. Now, how to remember this? This remembers the same as grade 1. Okay. Grade 2 and 3 of your VCUG. And RNC grade 3 is grade 4 and grade 5 of your VCUG study. Okay. So that is what it corresponds to. Now I told you idea is to avoid radiation exposure. Now you will say, sir, we already got ultrasound. Please note, when we did the ultrasound, we only looked for the sequelae. That means some sort of hydronephrosis, some sort of renal scarring, some sort of renal dysfunction. That is what we are trying to pick up on the ultrasound, not the actual vesicoureteric reflux per se. So if you want to pick up the specific vesicoureteric reflux, okay, for that you have to use a color Doppler. Okay, basically that's called as sonographic detection of the reflux. So you use a color Doppler and sometimes echo enhancing contrast agents to try and map out that area with a lot more clarity. That means in order to avoid radiation exposure, if you use a color Doppler, you will be able to see the jets of urine coming into the bladder. At the same time, you will be able to identify the reflux as well. Now, this is not done in your regular ultrasound. In regular ultrasound, we are only looking at complications of VUR rather than trying to diagnose the VUR, that is a vesicoureteric reflux. So next investigation we'll talk about is the cystoscopy and the positioning of the installation of contrast cystogram. Routinely, we don't perform the cystoscopy. Okay. Modern management of VUR does not include performing a routine cystoscopy. Why? Because whenever you're doing cystoscopy, from the outside, the bacteria can be pushed inside the bladder because through the urethra, you're putting your camera. But in a select group of patients where they have recurrent febrile urinary tract infection, you are suspecting a VUR, you have performed a VCUG and the VCUG says there is no evidence of VUR. But you have the strong suspicion, no, there must be some reflux. So what you do, empty the urinary bladder, put a cystoscope inside, put some dye in and around that particular vicinity of the ureteric orifice and get out. If there is a true reflux and you have put them in a dependent particular manner with regards to the position of the patient, the dye will reflux into the ureter and you should be able to pick it up. First you are going to do this, then turn the patient to the opposite side so that that particular ureteric orifice becomes the dependent position. Again put a cystoscope, put some dye there, get out and then evaluate the urinary tract. That is called as positioning of the installation. That means you are trying to instill a dye. So you will put the patient into position and then put the dye there. And what is the dye? It is a contrast and you're performing a cystogram at the end of it. That is what is the role of cystoscopy in VUR. But in general, for treatment or diagnosis or management of VUR, cystoscopy is not recommended. So what are the other investigations? You can have uroflowmetry and electromyography. Now this comes down to the fact now we are dealing with secondary vesicoureteric reflux. So unless you treat the secondary cause, you will not be able to treat the VUR. Okay. So treat the cause which is causing the secondary VUR. That is more important. If you treat this, automatically the VUR will become better. Now there is no role for invasive studies such as the urodynamic study. Okay. Urodynamic study means you'll put a sensor onto the bladder, see what is the intravesical pressure. I'm not bothered about that. Instead, what you can do is you can perform a uroflowmetry. So this will tell you what is the pre-void, what is the post-void, how much is the peak flow rate, what is the average flow rate, all this information you're going to get. Okay. Second is performing a electromyography. So this electromyography will tell you what is the condition of the pelvic floor muscle. Okay, it will tell you what is the function of the pelvic floor muscle. Now, this uroflowmetry and electromyography, you will have certain abnormalities, especially when you're dealing with lower urinary tract dysfunction and the bladder and bowel dysfunction syndrome. Okay, in both these scenarios, there will be some sort of abnormality in the uroflowmetry and the electromyography. Now, there is certain ways of reading this particular investigation. Whenever there is lack of smoothness of the flow velocity curve, it is telling you that there is some amount of post-void residue. So basically there is incomplete relaxation. So because of that incomplete relaxation, urine has not come out completely. There is still some amount of stagnated post-void residue that is sitting there. Now, so far we were only talking about vesicoureteric junction. But what happens? What is the sequelae? Eventually, this vesicoureteric junction will lead to some sort of problem in the kidney. So, it's your job to look at the kidney. Okay. So, look at the upper urinary tract. Okay. The upper urinary tract imaging. Now, main thing before we look at anything else is to try and differentiate it between two particular causes for this. See, I told you all this is some sort of embryological problem, right? Where the ureter kind of joins the bladder too soon. Now, if there is some embryological problem here, can you also have some sort of embryological problem higher up in the kidney? You can have, correct? You can have some sort of dysplastic kidney. You can have some sort of dysplasia. So, when this happens, the kidney is not functioning, correct? There will be some amount of scarring. Now, your job is to try to differentiate the scarring because of pyelonephritis or because of a congenital problem. So, because the VUR is also a congenital problem, it can be associated with both of these, either because of the pyelonephritis or because of an associated congenital abnormality. Okay. So, remember, the pyelonephritis that is caused because of the VUR can cause renal scarring. It impedes the attainment of the full renal growth potential and thereby increasing the risk of renovascular hypertension. That means it increases the risk of the patient developing hypertension. Now, your idea, like I said, is to differentiate between a vesicoureteric reflux and a congenital dysplasia, medicorenal disease, and a hydronephrosis. So, these are the things that you are trying to differentiate between. One of the investigations that we use there is the renal sonography. Okay. Idea is perform this in neonates. Why? Because you will have a baseline value. Okay. You know what is the condition of the kidney, what is the amount of scarring, what is the corticomedullary differentiation. As age progresses or as the disease progresses, this might also progress. Your findings also might progress. So, you need to have a baseline. So, in this renal sonography, the points that we are looking for is loss of corticomedullary differentiation, increased echogenicity. Okay. Now, if these two are there, it indirectly suggests that there is some sort of renal function abnormality. And like I said, your job is to try and differentiate it between acquired problem versus a congenital problem. Then keep these patients on regular surveillance. Again, here what they say is it is always better to do a non-invasive detection of the large cortical deflects or renal size asymmetry. Okay, always preferable to do a non-invasive detection. So, whenever we say non-invasive, the best one is your renal sonography. What about renal scintigraphy? Renal scintigraphy is basically your DTPA, DMSA and your MAC3 scan. Again, all this we have covered whenever we spoke about imaging modalities for the kidney. So, in renal scintigraphy, DMSA is more of an anatomical sort of an agent which is kind of harbored inside the kidney. So, whenever we use the camera, you can see the exact shape of the kidney, how much of it is functioning, because that is what the area which has taken up that particular radionuclide, and how much is not functioning, and this non-functioning will be photopenic. That means it doesn't take up anything, it doesn't give out any particular radiation. Now, this particular DMSA imaging can be obtained to assess the status of the kidney for scarring and functioning. And there is something called as a top-down approach. So, there is a school of thought which say that first do this DMSA scan before doing ultrasound, before doing VCUG, before doing all of that. Do a radioscintigraphy, okay, or a renal scintigraphy scan. If there is scarring, if there is some sort of non-functioning kidney, then you evaluate. That means after that point, you are going to evaluate with the help of ultrasound or a VCUG. Now, they found this very cumbersome and not all peripheral hospitals will have access to this particular dye. So, eventually this idea kind of died down, and that is what is called as the top-down approach. That means first do the DMSA, and then once you have found some dead tissue or non-functioning tissue inside the kidney, then do a proper evaluation and to look for further reasoning into why that has happened. So, in the presence of pyelonephritis, there will be impaired tubular uptake. So, this will be a photopenic region. Your idea is to try and differentiate between acquired and congenital defects. This we have already discussed. Now, the last point that this particular renal scintigraphy will help you with is whether the patient needs reconstruction or the patient needs resection. If it is viable tissue, that means which takes up this DMSA. If it is viable, you will plan a reconstruction. If it is a non-viable or a dead tissue or just a big cyst or something of that sort, you will plan for a resection. Okay, it's as simple as that. That is the advantage of having a renal scintigraphy. Now let's talk about the NICE guidelines. That means when are we going to evaluate these particular patients?